It's yes, sir.
Thank you. Good morning. It's a great pleasure to welcome you all to another Manthan meeting. We are today going to talk about a very challenging topic, namely attention deficit hyperactivity disorder. Diagnosis of ADHD is always a challenge, whether it is in children, adolescents, or in adults. At the moment, we rely a lot upon subjective reports, clinical interviews through some structured interview schedules, but yet the varying symptom presentations across age groups can pose a challenge. Once again, the overlap of symptoms can occur in many conditions, resulting in differential diagnosis. I think we always talked about objectivity in psychiatry, and objectivity in terms of biomarkers has always been a challenge, but that's what we have been talking about all the time in psychiatric disorders. And I think ADHD is no exception. At the moment, we are looking at some biological markers and trying to incorporate it into the diagnosis of ADHD to make the diagnosis more objective. To highlight about these issues, bringing in the objectivity to the diagnosis of ADHD, we have with us Dr. Srinivas Rajkumar. He's a very young, dynamic psychiatrist. He's at the moment working in Sri Balaji Medical College Hospital. People who interacted with him know he's just not only young, but he's full of ideas and enthusiasm, very bright psychiatrist. And I think he brings a lot of enthusiasm with him and brings in the flavor of biological psychiatry into the field. And he graduated from AIIMS, New Delhi. 2017, he graduated from AIIMS and then he joined Sri Balaji. So it's always a pleasure interacting with Dr. Srinivas Rajkumar. So I'm so grateful to him for accepting this offer to talk about a very nuanced topic like ADHD, the objectivity. The subject has already kindled interest in the minds of psychiatrists in the sense that Dr. Karthikeyan has already posted a few questions in the box and asked people to think about it. So here is Dr. Srinivas Rajkumar. You are amidst a lot of experts here. By Dr. Jayantini is a leading expert in the field in the country. So we have so many other experts worked in the field for longer periods of time. So I'm very, very happy you're going to be presenting to us on ADHD objectivity. Over to you, Dr. Srinivas Rajkumar. Thank you for your presence.
Thank you for the warm introduction, and thank you, seniors and colleagues who have joined the meeting. And without further ado, I think we'll go to the presentation. As sir mentioned, the quest for biomarkers in psychiatry has been a long, so as to say, an elusive, quest which has spent several $1 billion. But we have made small progress compared to the investment that has been made. The fundamental issue with psychiatry is how the psychiatric illnesses have been classified. For example, if we compare the classifications, for example, if you see the periodic table, all the elements are clearly labeled. There is a clear demarcation between one element to the other, and they are discrete, so as to say we can differentiate one element from the other. Medical classification is somewhere in between, based on the etiology, that is at least for communicable diseases and many non-communicable diseases. We are able to have a certain cause, that is etiology, which further guides the presentation of the illness. Then we go on to develop measures for cure or prevention. But so as to say, in psychiatry, the causes are complex, that is multifactorial, and again, they are poorly understood. And again, symptoms vary widely, even in single cause conditions. For example, even if we map the loci to a specific region, the same chromosomal region can be responsible for illnesses of extremely opposite polarity. So as to say, 22q11 can be implicated in both schizophrenia and also in ADHD, so as to say. So two illnesses with exact polar opposites in the neurochemistry. So it is difficult to classify psychiatric illnesses by cause alone. So this is the latest perspective, but even since the beginning, So this is not a recent phenomena that we have an issue with the classification of psychiatric illnesses. Ludwig Wittgenstein, a philosopher, described that classifications made by philosophers and psychologists, which can be extrapolated to psychiatrists, are like trying to classify clouds by their shape. So we know it exists and we give an arbitrary boundary, but we are not able to differentiate one from the other, and we are also not able to, extrapolate it into other dimensions. But this is not the issue only with psychiatry. Even early in medicine, just when a surgeon saw a swelling, he just removed it. There was no mention of whether it was malignant or benign or what were the histopathological findings. But modern medicine has evolved since then. For multiple illnesses, we have biomarkers, and we are able to perform adequate measurements. For example, for diabetes, we are able to measure the blood sugar. And for hypertension, we are able to measure the exact blood pressure. ICD and DSM, as it stands today, the diagnosis is based on symptom clusters. That is, for ADHD, it is inattention, hyperactivity, and impulsivity. They take a categorical descriptive approach. Though Ardagh, the proposal, had very ambitious vision for psychiatry, it fell short of expectations, mainly because of the difficulty in deploying all the 7 pillars of Ardagh, and also about utility. It is very difficult to incorporate Ardagh into everyday clinical assessment, though some of the domains help in understanding the illness per se, but not actually translating to improved diagnosis per se. So psychiatric illnesses can be even as early as 1913 proposed that there are true diseases. That is, you can clearly differentiate between normal versus abnormal, so as to say in general parasis. Then circles, we know it is abnormal. That is, there is differentiation between the entity and normality, but not among themselves. For example, bipolar affective disorder and schizophrenia. Then there are types which don't have clear boundaries with normality nor among themselves. That is, example is among neurosis, abnormal personalities. So where does ADHD fall? So ADHD, if we try to fit it into Asper's definition, it is somewhat like a type, not a true disease. So the symptoms of ADHD, that is inattention, hyperactivity, and impulsivity, exist on a spectrum, and they overlap with normal behavior and also with other disorders. Because inattention can be present in anxiety, mood disorders, learning disabilities. Even other dimensions of ADHD can be present in these disorders. So as the diagnosis stands today, there is no single test or biomarker which can make a conclusive diagnosis of ADHD. And the diagnosis, as with other illnesses, is based on clusters of behaviors and their impact on functioning. And again, the presentation of ADHD is highly heterogeneous. Different people show different symptom patterns, and symptoms also change over time. To complicate this, ADHD is among the illnesses with profound set of comorbidities, not only mental health, but also physical health comorbidities. We often encounter patients with ADHD having ODD, conduct disorder, and there is up to 50% or even more prevalence of anxiety disorders, close to 50% prevalence of mood disorders, then 30 to 40% prevalence of learning disorders, and again 40 to even 60% overlap with autistic spectrum. Then there is increased prevalence of substance use disorders, tic disorders, and OCD. Adding to the mental health comorbidities, there are physical health comorbidities like obesity, which can be prevalent up to 40% in children and 70% in adults. Sleep disorders, epilepsy, migraine, chronic pain, myalgia, cardiovascular and metabolic diseases also accompany ADHD. So with this description, while trying to objectively diagnose ADHD, the question we have to ask ourselves is ADHD a clear-cut or a well-established diagnostic entity? And have we described ADHD in a way nature defined it so as to look for biomarkers and discover it? But so as to discuss, a lot of things in nature don't have specific joints. For example, even meaningful distinctions like between day and night, adult versus child. We keep on changing the age, how we see the child OPD versus adolescents or adults. So ADHD symptoms in the similar fashion overlap with normal behavior. Then again, attention levels vary among individuals, and distinguishing normal variation from disorder is challenging. And ADHD symptoms exist on a continuum, not as discrete entities. And we have norms according to age also. So finally, in DSM and ICD, we had come to a conclusion that we cannot make a diagnosis unless there is distress and dysfunction. So the increased emphasis is based on the functional impairment, not just the presence of symptoms. So what do we see in clinical practice? So we see either pure ADHD, so as to say, with ADHD alone without any comorbidities. Then we see individuals with personality disorders presenting with almost similar set of symptoms. That is, they present with inattention, hyperactivity, impulsivity, and emotional dysregulation, which is common to ADHD, but it does not deserve a place in the diagnostic criteria. Then comes the concept of ADHD or autism plus ADHD. As DSM-5 has allowed dual diagnosis, there is increased emphasis on describing both autism and ADHD if present, because it has implications both on like diagnosis, then again, choice of pharmacotherapy or other therapies. So the overlap is within the neurodevelopmental spectrum with personality and also with mental illness. So after such difficulties in making ADHD diagnosis, there was an emphasis on looking at the lifespan of an individual. For example, when the patient presents. So there has been some change in the age group. That is, like we have expanded the age of onset of symptoms to 12 years. Then again, the presence of symptoms should be in more than one setting. So this again causes trouble. For example, if you see a doctor's room, which is also a setting that requires optimum performance from a child, and particularly with ADHD, where they are being monitored and the environment is tightly regulated, their performance may not drop significantly so as to make a diagnosis. And again, the evolution of symptoms from childhood to adolescence to adulthood, there is change in the profile of symptoms. So from predominantly hyperactive, impulsive presentation to there is progressive decline in hyperactivity. And in adulthood, there may not be any visible symptoms, but it may be reflected as internal restlessness, disorganization, difficulty with time management, which is described as so as to call executive dysfunction. And even though ADHD was seen as a disorder of childhood, now we know that up to 60% of the individuals have some form of symptoms which persist well into adulthood. So most of the theory points towards the fact that true adult onset ADHD is rare. And if there is late onset inattention or hyperactivity, it may be due to other causes other than to be, defined as ADHD. And the functional impact of ADHD is far more than which was predicted. So it affects academic, work, relationships, emotions across the lifespan. Then the high rate of comorbidity only worsens it. So 10 years back, when RDoC was pushed by Tim Insel, the prediction was we will have different frameworks to define illnesses so that the quest for biomarkers and objectivity will improve. But where are we in 2025? Okay, there has been vast interest in ADHD related publication trends. Tim Insel, almost the RDoC was abandoned, and Tim Insel moved on to pursue his career in Google and now to his own startup. But the interest kindled by RDoC and other objective measures still continues. For example, there are few tests which have been deployed in major health systems. For example, QbTest, that is quantitative behavioral test for ADHD, which is an add-on evaluation to regular clinical interview, got FDA clearance and it has been incorporated into NHS use. And this is from NUS Singapore. So as close to 90 minutes, a complete evaluation for ADHD will be complete and the treatment can be planned. Then again, as I mentioned, even though ADHD is seen as a disorder of, say, dopamine deficiency or dysregulation, even at the opposite end of spectrum, like the risk of schizophrenia in probants is up to 30%. That is an article by Machari-Keshavan. So previously, when the search, that is the search for objective markers started, everybody wanted to replace the clinical interview with one test or a set of tests which can be administered completely by a computer, or we can look for some biomarkers in the brain either by functional imaging, structural imaging, or some electrical signals. So something which can point to the diagnosis. But this is not how medicine evolves. So as we know, when we have tests of average sensitivity and specificity, we usually combine them. We do serial or parallel testing so as to improve their ability to predict illness. So an approach to improve objectivity in ADHD should also be in the similar lines. So here we will discuss few of the approved and upcoming objective methods which can help to evaluate ADHD. So the purpose, for example, when major systems like NHS are able to incorporate such tests, what is their goal in mind? In addition to objectivity, they also feel that the time taken to evaluate an individual decreases when such objective tests, which look for measures which human beings cannot observe. For example, even if a human being is going to do a performance testing, for example, if you look for go, no go, obviously, you can do with hand also, but how will you measure it? So in the current state, computers can do certain measurements which human interviewer or a person who tries to analyze cannot do. So here we'll discuss about NEBA, QbTest, fNIRS, and some of the performance tests. So NEBA has been approved by FDA. I'll describe NEBA. So NEBA stands for neuropsychiatric EEG-based assessment. So FDA has approved it as an adjunct measure for age groups 6 to 17. So it measures the theta-beta ratio just with 2 electrode placements and 1 more reference electrode. So in 15 to 20 minutes, the resting state EEG is recorded and there are normative tables. So by comparing the theta-beta ratio with the normative reference range, a diagnosis of ADHD, that is at least by the likelihood, okay, you can make a prediction of how likely the person will have ADHD. And we know that theta is associated with drowsiness, inattention, and mind wandering. Beta waves are associated with alertness, focus, and active cognitive processing. The ratio actually is measured. In addition to NEBA, there are certain researchers who have incorporated additional spectral processing to improve the accuracy of data, but those efforts have not fetched FDA approval. So why 6 to 17? So beyond 17 years, it has been seen that theta beta ratio is not a great predictor of ADHD. Then we come to fNIRS. So we all know fMRI. fMRI is done in strict closed rooms with huge difficulty, and the facility is not available everywhere. So fNIRS is functional near infrared spectroscopy, which is a portable alternative to fMRI. So the mechanism is very simple. There is a central detector and two emitters are placed on the opposite side, or even so there are a set of electrodes are called optodes, so as to say. There is an emitter and detector which travels a banana shaped path in the tissue. So in comparison to fMRI, which can provide activity from the entire brain tissue, or at least most of the superficial regions, fNIRS has access to only the superficial regions of the brain. But our area of interest, that is the prefrontal cortex, is located superficial enough for us to access using a technique like fNIRS. So as you can see, when we started our research in fNIRS, we did not have portable modules, but now we have portable devices which the patient or the individual can wear and go to work or go to do some physical activity, and we can have a prolonged data from the patient. The criticism with most of the functional imaging modalities is they are done at ideal settings, and even the choice of tests is based on whether it can be used in a restrictive environment like MRI chamber, and whether the response by the individual can also be provided in an appropriate manner. But fNIRS offers greater flexibility, particularly for children who may be hesitant to sit in a closed chamber and undergo fMRI. fNIRS has some advantages and some disadvantages. The main disadvantage being it has only moderate spatial resolution, but everything else appears good because it is very portable, the cost is low, you can look for the changes in brain oxygenation in naturalistic real world scenario. And though this is a limitation, depending upon our condition, fNIRS is a robust alternative to fMRI for seeing specific regions of the brain. So the usual findings in fNIRS. So earlier they used to do like basic heat map kind of assessment. That is, normal controls have a heat map of the brain regions. Then when we do fNIRS for patients with ADHD, they again have a heat map. So this is compared with the normative data set, and then we make a prediction regarding potential areas of decreased engagement during the task. So the usual tasks used were NBAC and Stroop, which we also used in our research. And both the cognitive performance and during the same time, the extent of brain activation is observed. So here again, one would expect that there would be clear-cut findings between cognitive performance and brain activation. But the actual findings are far from what we would expect. So based on these findings, like even the extended hypothesis of brain operates not as specific regions, but as network, became popular only after fMRI findings started to show that human brain has inherent plasticity, that if a patient is able to perform the task as close to a normal individual, even if there is hypofrontality, there are other regions in the brain which can be activated. But the main limitation of fNIRS is because it doesn't show deeper regions of the brain or other networks. There are patients who show close to normal task performance, but still will show hypofrontality. So this is the basic band which we used, and the region of interest was prefrontal cortex, and our studies showed hypofrontality. Now we have huge access to fNIRS database, where if we do, though they are not like Indian data, we can still compare the findings from fNIRS to the data set and make reasonable prediction. And in addition to the very primitive heat map based analysis, now we also have like sophisticated tools to perform complexity analysis. That is by using basic machine learning techniques like vector modeling. We can still look for details which are not visible in standard heat map based visual representation. So these are the databases which are freely available in the internet. So why I am discussing fNIRS, which is so far seen as a almost lab-based or very expensive utility. Things are changing, okay, with the miniaturization of circuits and availability of so many startups working in this domain. Now we have portable equipments of the cost of say close to $500. We can get a equipment which is though marketed as a commercial equipment, provides raw data from the device for our assessment. So this is one such device which is in its third generation, Musesetina, which combines 4 EEG sensors, 5 fNIRS optodes positioned along the forehead, targeting the prefrontal cortex. So here we can do both, like for example, whatever NEBA does, that is the EEG, resting state EEG, even task-based EEG assessment. In addition, we can also do resting state fNIRS, task-based again fNIRS, and it also has additional sensor for heart rate variability. So such devices are available even for layman to use, more so for people interested in research to access the raw data and do additional analysis. So fNIRS has come from just like fMRI came to the lab, that is outside the sophisticated diagnostic setup. Now fNIRS has come to clinic and even to homes. And in addition, this doesn't stop only with detection of the biosignals. We can also provide neurofeedback using these devices in a screen-based presentation of protocols. So from this, we'll move to computerized tests of attention. See, the interest in computerized tests was always there, but the difficulty was with designing a task which would adequately reflect the neuropsychological defects in ADHD. The problem is attention as a neurophysiological entity can be detected by tests, but the specific attention defects present in ADHD, or so as to say, or the lack of a specific attention deficit, makes it difficult to design tasks. But some progress has been made in this domain, and we have some of the approved tests which I will be discussing now. So the neuropsychological deficits in ADHD are selective attention, working memory, processing speed, reaction time variability, motor speed, visuomotor coordination, poor cognitive flexibility, poor inhibitory control, and executive functioning. And some of these defects can only be detected by computer-based assessment. Even though like most of them who would have gone through the neuropsychological manual would have seen 1 back, 2 back, and the norms of Niemann's. And you would not believe like the scoring was done manually. That is based on the performance of the entire card set help to assess or score an individual, which is a very, very inaccurate way to assess the overall cognitive deficits. So now we have like tests with specific subsets which will assess for specific neuropsychological deficits. So some of the tests are CONUS, TOVA, IVA2, QbTest, and MOXO CPT. Among these lot of tests have like huge criticism. We will just discuss QbTest and MOXO CPT. QbTest because QbTest has approval from FDA, not as a diagnostic entity, but it as an additional test that can be performed to aid in diagnosis. And NHS has incorporated QbTest. And again, we should ask questions about why a test is being incorporated into standard evaluation guidelines. So in UK, they saw that the average time to diagnosis and initiation of stimulant or other treatments can be as high as 18 months. And also, the number of patients visiting or who have initiated ADHD evaluation, 30% of the individuals did not have a diagnosis or they were not started on treatment in 6 months. So the introduction of tests is for both convenience and also the kind of objective measures it employs. For example, QbTest is a combination of, though we see that cognitive performance tests or this continuous performance test assess only for the cognitive deficits, that is, they assess for inattention, then other specific deficits, then the kind of impulsivity can be assessed. Infrared motion tracking helps to assess hyperactivity part also. So QbTest assesses almost all aspects of ADHD and provides a score. And studies have shown that if a clinician was provided access to QbTest scores, he's likely to make a diagnosis faster and initiate treatment with greater confidence than one without it. MOXO's CPT just upped the game. What they did was, all these tests, the main criticism of these tests is, this reflects the optimum performance of an individual. For example, an individual with ADHD may have difficulty performing his homework, which may be very simple yet boring, but he may be able to play complex video games, which require huge amount of strategy, which requires so much of like all the response inhibition, then it would require like quick motor response, all those things which are thought to be deficient in an individual with ADHD. So MOXO CPT tries to emulate a real world setting by introducing distractions while a person is performing the test. So there are both visual distractors, auditory distractors trying to get close to a ecologically valid assessment. So again, even though when we have a computerized assessment, we always expect that it would have great sensitivity and specificity. But the truth is far from that. Okay, the sensitivity of these assessments are close to say 80s or 70s. And even diagnostic agreement is 70 or even less. Some of the tests have been criticized, mentioning that this is the test you should not use in ADHD. The criticism has been more for TOVA. Other tests have reasonable sensitivity and specificity. Moxo CPT has a huge profiling of subdomain scores. Impulsivity index is slightly poor, but other domains are reasonably assessed. So Moxo assesses an individual in 4 domains: attention, timeliness, impulsivity, and hyperactivity. The task design is the very important part, right? Some offer fixed timelines and fixed stimulus presentation, which is a poor way to assess the cognitive deficits in ADHD. But Moxo uses variable duration and different types of stimulus to assess for ADHD. So Moxo CPT reliably distinguishes ADHD from controls with an accuracy rate of 85 to 89%. And as I already mentioned, it has good ecological validity because it incorporates real-life visual and auditory distractors, making it more representative of everyday attentional challenges an individual is likely to face. Then the indices are comprehensive. As we saw, there are 4 indices, and it tries to capture the illness close to its presentation. And it has embedded validity scales, so it can be helped to detect malingering, which is a common issue we face because people want to have a fancy diagnosis of ADHD. This is the diagnostic criteria. I think in ICD-11, things have been simplified so much so as to say the emphasis should be on functional impact rather than checklist count. So here comes in a huge problem. If an individual presents with ADHD, with inattention, so as to say, and provides answer on all of our self-assessment questionnaires as yes, it becomes very easy to fake a diagnosis of ADHD. But rather than describing that a patient is faking a diagnosis of ADHD, just as we deal with psychosomatic illnesses, okay, we are not able to identify a reason or label it, but that doesn't mean that the patient is not suffering. So in such conditions, the patients may have inattention, the patient may have difficulty sitting still. The problem is the underlying maybe something else, say like anxiety disorder or some other condition that is causing a deficit which mimics ADHD. So this is a detailed NUS objective protocol, National University of Singapore, which has incorporated fNIRS, an eye tracking test, a continuous performance test, and the full assessment, as I said, can be completed in 90 minutes. Each objective test has an accuracy of approximately 70%. So though this protocol has an accuracy of 70%, so just as I said, we should not look at any single set of tests as a replacement for clinical judgment. But if this data is provided to a clinician who goes on to do a clinical interview, or this data is supplemented to a clinician who has already done his clinical assessment, it helps to start the treatment early and to make a more confident diagnosis. So now the question comes, not about ADHD alone. In entirety of psychiatry, we give so much importance to subjective experience. For example, even in depression, the questioning is we ask about patient's mood, patient's energy level. And though we may be able to corroborate it with the kind of functional decline or other difficulties the patient is facing from the patient's relatives or where the patient is employed, still the emphasis on subjective experience is high to the extent that we do make overdiagnosis or underdiagnosis. So in ADHD, the question is always between, should we ask the patient or should we do an objective evaluation? For example, if you see a kid sitting still in throughout the interview, answering every questions perfectly, but if the mother comes and says that he's not doing well in classroom, and even if you get a teacher report, it states the same. How likely are we as clinicians likely to make a diagnosis of ADHD? That is what is observed versus what the patient undergoes in real life challenging situations. So Montaigne boldly states that the mind cannot see itself, or even Plato in the Allegory of the Cave states that we cannot see our mind directly. From what is reflected as shadow from us, we have to observe how we look. But should we cling on to such measures, that is what we see versus what the patient experiences, or should we move beyond that? The question of self-diagnosis is another thing I think Karthikeyan sir has also discussed. So recently, a lot of celebrities have declared, particularly with the explosion of podcast culture, everybody wants to come on the TV or the podcast and say that they have been suffering from, say, poverty in childhood, something like, or a disrupted family, or a mental illness, so that they can say that they are somebody who has overcome it and achieved something meaningful. There may be real sufferers, but the kind of descriptions these celebrities provide on television or on podcasts may do more harm than good. And after every interview or after every some podcast goes viral, we as clinicians see patients with like copycat symptoms. They come and describe almost typical symptoms. And while they are presenting their symptoms, they also say that what I say may look like I have made the notes from ChatGPT, or I have read the internet regarding the terms, which puts us in serious, in difficult situation, whether to accept the symptoms or move towards objective evaluation. So as I said, the self-diagnosis may stem from a lot of other motivations, like influenced by social media and online content. Particularly the TikTok, though TikTok was banned in India, in other countries, there has been an increased number of patients presenting with symptoms which are popularly shown in TikTok reels, which mostly contain misrepresentations of ADHD symptoms. That is, mostly they combine symptoms of autism, ADHD, and other personality disorders and present them as extended symptoms of ADHD. And generally, it is a human tendency to seek a closure if somebody has not been able to perform. They look for causes outside. And when the search for causes outside ends, they search within themselves that there may be some psychological condition that is preventing them from their potential. And ADHD is one such fancy diagnosis people choose to identify with. And again, because of the overlap of symptoms, for example, a patient comes and declares that he may have ADHD. A detailed clinical interview would reveal that patient may have anxiety, depression, sleep issues, or it may be just a result of stress or substance use or even withdrawal. And online self-assessment tools. So most of the online quizzes and checklists, because of their simplicity and to keep the takers engaged, they provide very simplified questions. And most of the scales have Likert type questionnaire. So most of them fill the highest scores so as to get it done fast and present with false positive scores. And again, as I said, culturally, if some of the diagnoses are related with celebrities and high achievers, people tend to identify with those diagnoses. So from whatever we have discussed, tools like continuous performance tests, MOXO CPT, NEBA, fNIRS provide valuable quantitative data on attention, impulsivity, and brain function. So before we go to the close of this presentation, there may be a lot of questions regarding, so now because you have made a presentation on these tests, do we go and start buying these tests or get licenses for the same, and should we apply? So we must see that these are not the only tests that are available. There are a lot of open source libraries which have even more sophisticated tests to assess for cognition. You don't have to get a specific device for eye tracking or motion tracking. A simple webcam can be programmed to do motion tracking. So even though, and already you know that, like, except for MOXO CPT and QBT, like Indian norms are not available. So it is better when we start our journey towards objectivity, we can look at open source tools to assess for cognitive performance and also other dimensions, that is hyperactivity. And even fNIRS, as I said, we have a lot of open source toolkits. And particularly with the advent of publicly available AI tools, lot of assessment can be done by us as individuals without relying on sophisticated software packages to do the analysis. So the role in diagnosis of these tests is, these evaluations can supplement, but they do not replace the clinical interview and subjective experiences. The problem with rating scales, one may ask, why not stop with rating scales? Most of the scales available for ADHD are Likert based. Okay. And again, the information gained from parents, teachers, if you ask whether to give 1, 2, 3, or 4, it is very difficult to get an accurate description of the symptoms. So always supplement clinical assessment or even rating scales with some objective measure, particularly cognitive tests, which can be easily performed. That is computerized cognitive tests. So the best practice would be to combine objective measures with comprehensive clinical evaluation for reliable evidence-based ADHD diagnosis and management. And in this regard, we also have a research project which is now underway. So hopefully we will generate some Indian norms and some simple do-it-yourself devices which can measure some of these parameters. So the question is, ADHD, is objective diagnosis possible? The answer would be a patient who has typical history of ADHD, no indication of alternative pathology, poor performance on continuous performance tasks, and a beneficial response to a stimulant probably has ADHD in its purest form. Others have a mix of lot of things, as with other psychiatric diagnoses also, because the divisions are not pure. So I'd like to extend my thanks to Professor Sagar, who introduced me to fNIRS, Professor Rohit sir, who guided me in the process, Professor K.K. Deepak sir, who arranged the devices from the Department of Physiology. Ashley sir, who was the senior resident and helped me with the data analysis. Satyaprakash sir, who introduced me to the nuances of psychiatric classification, a lot of which has been reflected here. And these are the references which you can read, beginning from the evolution of a diagnosis and how things have progressed, and also the links to the data sets. So Alan Francis made a bold prediction that computers will eventually outperform clinicians in diagnosis, not because they are smarter, but because they are more consistent, less biased, and have access to vast databases. And this was like long back, while the DSM task force was convening. This can be seen even in the latest ICD-11. It is very difficult to, just as we used to memorize ICD-10 codes and be able to write a diagnosis. With ICD-11, it is difficult to remember and code. And even ICD-11 encourages to make a computer-based diagnosis. So you're supposed to look for specifiers, classify them, and arrive at a code rather than by hearting or using a simplified manual. So there is an increased trend to move towards computer-based reporting, computer-based diagnosis, and computer-based assessment, which in my view is good, though a lot of the psychiatrists may tend to disagree. But I think with this, we'll open the forum for discussion.
Thank you, Dr. Srinivas Rajkumar. As a young psychiatrist, you're at a. Can you just close the slide so that we can just see the people on board? Thank you so much. Thank you so much. As a young psychiatrist, you really made a very scholarly presentation on a very complex issue. You started off by saying the diagnosis of ADHD is challenging because of the fuzzy boundaries and the blood edges you called, and the differentiation between the natural and pathological symptoms that people exhibit, particularly, let's say, about inattention, for example, or overactivity. How do you differentiate? And categorical diagnosis versus spectrum, which is becoming more popular. But in the end, you said the diagnosis is primarily made on the impact it had on the individual's functioning. That's the most important factor. So you really emphasized on the overlap, not just with having physical comorbidities, but also mental health comorbidities, many comorbidities, sometimes more than 50% of the people exhibiting that. And you also talked about this ADHD, which is becoming very popular among the neurodevelopmental disorder circles. And then you said one of the most important factors in the presentation as it evolves is impulsivity and emotional regulation, but that's not given prime importance in any of the diagnostic criteria. So if you look at the lifespan perspective, you said the symptoms change, symptom profiles change over a period of time. And I think the disorganization, the time management, and the executive function disturbance that presents in adult ADHD is very predominant. And you said adult ADHD myself may be very rare, but the late onset ones have a different pathology altogether. So that's a very interesting take. I think that will all call for some discussion on that. So I think then you moved on to the crucial topic of biomarkers. You talked about the importance of biomarkers very early on. And you talked about your own experience with NEBA, the neuropsychiatric EEG-based assessment, which is an FDA-approved tool in our hands. And I think you alluded about it, the importance of theta-beta ratio, but also highlighted that it is very useful for diagnosing between the age of 0 to 17. Probably in adult ADHD, its utility in diagnosis is questionable because of the various reasons you talked about. So the theta-beta ratio, and that you can see below 17 is going to be a diagnostic importance. Then you talked about the fNIRS, the functional near infrared spectroscopy, the brain infrared scan. But I think you said it's now portable, and it's moderate in terms of, resolution. The spatial resolution is moderate, but it's got a very high temporal resolution. But you said the reduced activation of the dorsolateral prefrontal cortex during working memory and executive function tasks is a very important phenomena. You figured out that there is lowered oxygenation in the frontal lobe, talking about the hypoactivation of this prefrontal cortex. So you said also India has a database which contributing to the database, to the already existing database. I think those are the very important things you said. Now it's available not just in the laboratory, also in the clinic, but also home. There are homemade devices which people can use for their own training purposes. Then you talked about this continuous performance test, the computerized programs that are widely available, in which you really talked about the MOXA, CBT, and the QbTest as most important ones, and you highlighted the importance of it. One of the most important lessons you told all of us is that there is no single test available as a diagnostic tool for ADHD. I think that's a very important point. All of us have to remember there is no single test. Always a combination is more helpful. And you said the lived experience is central and important. That is why the clinical interviews are very central to the diagnosis of ADHD, which is a point that Dr. Karthikeyan talked about yesterday. And he also actually talked about some of the harms done by celebrities' self-diagnosis and how these online testings could be leading to false positive results. And I think I really liked your emphasis on saying that any of these tests that are available do not replace the existing methods of assessment and diagnosis. They only supplement it. You also said the clinical interview, which captures the lived experience, is central to the diagnosis. You said combining the tools, the clinical interview tools, with objective measure is a way forward. And I really, really appreciate the contribution that you made. You stimulated all of us. And I think we will be thinking about some of the tools that you talked about. And I guess, in the future, we'll be able to maybe able to make a better diagnosis in this particular complex disorder. Thank you so much, Dr. Srinivas Rajkumar. I really appreciate you, coming on board and then, wanting to talk to us given a short period of time. It's a brilliant presentation, very educative presentation. There are questions in the chat box. And if I can, okay. We'll ask the people to unmute and ask the questions. Can we begin with Karthik, because he already set the tone rolling by yesterday itself. And we have experts like Dr. Murugan. Unfortunately, Dr. Jayantini has to move for a batchmate. So she left just about a few minutes back. There were 90 participants at one point, 90 plus participants who participated at one point in time. I really appreciate your presence today. So can we ask Dr. Karthikeyan and then Dr. Murugappan? Karthikeyan, yes.
Good morning, everybody. I know Srinivas Rajkumar as a medical student in Madurai Medical College. He was doing his internship when I was assistant professor there. And he was one of the most intelligent students then, there, and now also. He's an enterprising person who is well known for his varied interests. He was a student leader in AIMS, and he was one of the very few people from Tamil Nadu who achieved a lot of things in AIMS for the benefit of patients and students in AIMS. And he's a very avid investor also. He started a group called Investing Doctors Group, and we have agreed with him. And he's one of the, future stars of psychiatry in Tamil Nadu. I sincerely thank him for his lucid, clear presentation about the objectively diagnosing ADHD. But I have some reservations. I want to clarify with Srinivas Rajkumar about it. If too much objectivity is stressed, and I think that the theta beta wave ratio, has it been, is there any ambiguity in it? Is there any strict, criteria like laboratory tests where there is beyond 40 it is abnormal, beyond 20 is normal? So, is there any specific cutoff mark in the theta beta ratio? One question. The second thing is, I think theta beta ratio is more it's an indicator of cerebral maturation, because after 17 years, it is not helpful. So, is it a generalized thing or is it specific for ADHD only? Because some people with depression, people who are on sedatives, people who are drowsy, people who have anxiety disorders, people who have epileptic disorders that are quite common with ADHD patients and on antiepileptics can confound the picture. The next thing you want to say is you clearly stress that it can never replace clinical examination. So I'm very happy that both subjective and objective experience is required. And finally, what is the cost of doing? Because I come from a place where I get to see more of poor, underprivileged patients and people from lower social strata. What is the cost of doing these investigations? And I want to clarify on this. These small practical points will be beneficial. But I am going in for EEG because my patients are asking for objective evidence. Because in other illnesses, in other fields, we have always have some CT scan or laboratory test to identify EEG. The parents of patients are much more aware now. They have access to lots of AI tools and books. They come prepared with lots of questions and peppers of questions. So I think using EEG, the first test tutor, be much more beneficial in confirming them to them, that giving them the confidence that this diagnosis is ADHD, even though we are clinically we have identified it as ADHD, giving an objective evidence may be convincing them and help in adhering to our treatment regimen rather than seeking for other alternatives. Thank you, Rajkumar. I'm very proud of you. Very happy to listen to you after a long time. Cheers.
Thank you so much, sir. Coming to the questions straight away, theta beta ratio, as we see with all brain waves, there are multiple determinants for a wave to happen and to be detected. And though the initial data was promising, even with theta beta ratio, over time, for example, at least with the advent of machine learning methods and other things, the profiling has been done to an extent that normative data, that is the norms, are available not only like our old times that we used to see a table that, okay, 9 to 11 years, then you mark this side, that side, then go and find, okay, where, in which standard deviation does the patient fall. Now there are norms for time of the day of the week, and the extent of like medicines patient is on, other comorbidities. So you can input multiple data before arriving at the output. Obviously, this comes at a cost because previously we used to have simple ready-made methods. Now everything is computer-based and everything comes from proprietary softwares. That being said, theta beta ratio is one of the easiest EEG signal to pick up. You just need 2 and you can get an extrapolated data. If you use 3, you can get an accurate data. And now you can see on Upside Down Labs, and there are several other startups who sell electrodes, the basic chip to capture data. Then again, the processing software is available for free. So we can easily circumvent these limitations which are present. Obviously, all these companies have used pre-existing open source data. These tests were known since the advent of neuropsychology. Everybody knows what go-no-go is, what NBAC is, what oddball paradigm is. But they have just standardized the norms. And particularly considering the lack of availability of Indian data, we should not be hesitant in starting somebody on this objective path of evaluation. So that being said, there are more sophisticated tests than what these commercial packages offer. For example, this attention network task. And there are set of batteries which can even run the test for extended duration to assess for the same deficits which we know are present in ADHD. So with the knowledge of neuropsychological tests, we can pick tests and we can provide to a patient in a personalized fashion and even do a better job than what this standard packages do offer. Then again, age standardized norm, even though the FDA approval is only for 6 to 17 years, so as to say, I think people who use QEEG extensively, particularly in the lab with Rohit sir had, and even Dr. Murugapan sir would be able to say that even in adults, we are able to see a difference in theta beta ratio. And even the conventional package, which is available with those devices, is able to do a reasonably good job. And with the advent of AI, if the patient comes equipped, we are also better equipped to do analysis, download these open source databases, and also we can do it. Then again, like for example, EEG signals are a combination of multiple factors. So this can be a useful add-on. For example, if you do a specific task, then see the task-based EEG or do the resting state, it can serve as an adjunct. And sir asked about, yeah, sir asked about the cost. So I think this answers the question about cost also. If we are worried about cost, we can choose open source alternatives to perform the same. Then, for example, Moxa CPT, even if you ask like any of the AI agents, say Claude or ChatGPT or other things, if you input the sequence of steps, it is able to generate a simple HTML to deliver tasks. So if you can sit with it for some time and design the task, it is able to provide both visual and auditory tasks. And because these tests were designed in, so because these tests were designed abroad, even the stimulus or distractions are not specific to Indian context. So when we make modifications, we can obviously incorporate Indian distractors, what our people face in everyday situations. And obviously, over time, we can generate norms for the same. Then regarding brain mapping, I think Murugapan sir can provide a overview on brain mapping. So I do refer some patients to Murugapan sir, but brain mapping is not usually done. If patient asks for objective markers, the better answer can be, okay, obviously you experience inattention, but we can explain the causes, that is the multiple other mental health issues and other contributors to inattention, poor work performance, procrastination, rather than just pointing out as ADHD. Then because this push for objectivity has also resulted in infamous practices. For example, everybody knows Daniel Amen of Amen Clinics. He was notorious to say that every patient who visits him, or even a person who comes to speak business deal with him, he would do spectre. This was his bold claim, and still he continues to run Amen clinics through several parts of US and still continues to do so. So that is stretching things to another extreme, right? Very expensive investigation with unproven, like validity, so as to say.
Before I ask Dr. Murugapan to come in, Dr. Soumya, do you want to say something? Dr. Soumya, please.
Yeah, good afternoon, everybody. I think this was a really enlightening presentation and something that we need today. Because I think earlier when I just started practice, I used to think, what does making a diagnosis, making a diagnosis, and what does a diagnosis mean to the person in terms of stigma? And now I find myself thinking, I have to make a diagnosis, but what does this diagnosis mean to the young person in terms of identity? So I also see myself in a tricky thing, because I have parents who might say, look, this person looks absolutely okay, but they're saying they have ADHD. And with the kind of symptoms and the availability of it online, which helps people recognize problems, but also one wonders, like I had a girl with ADHD, and the elder brother went to UK and he needed accommodations. So then he came back to Coimbatore and then went to another psychiatrist, told all the symptoms and got a letter for accommodation. And they said to me that they didn't come to me because I would know that the other person didn't have ADHD. So that makes me really, really scared that, okay, what does this mean? And puts me on high alert. So I'm also thinking about the pressure that it puts on the clinician in terms of when you give a diagnosis. So I think, which is not to say that this is a replacement to what we are doing, but it helps us and it assists us in what we are doing. So I think so that we can really, because we know that ADHD medication makes
இந்த இலைய மட்டும்
such a difference to people in terms of their functioning, so that people can really get the help that they deserve. So I think I'd be really looking forward to using these things in order to help me in my practice. Yeah, thank you.
Yeah, again, on a short note, see, when patients come for certification, we should deal everything like a medical legal case. So just as all the guidelines recommend, in addition to subjective clinical interview, you are supposed to get a report from a psychologist performing an objective evaluation. For example, when in doubt, we send for diagnostic psychometry. So the same way in ADHD also, we can do some performance tests which are hard to cheat, because I think with Moxo there are like scores to detect people who are malingering. Same with lot of other psychological tests also. If patient is answering yes, 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 there will be like inverted score somewhere. So we can detect, and particularly with continuous performance tests which last for a long time, the patient cannot grade their response in a particular fashion. And if it is far deviant from what is normal for the age, it will obviously show up.
Dr. Anup? Dr. Anup?
Yes, sir. Yes, sir.
Yes, yeah.
Sir, good afternoon, sir. An excellent presentation, sir. I just have two questions I need to ask. The first one is the fact that so ADHD, so like most of the tests that you have told are basically tests which are like an artificially structured test, like a go no go or a trait test or all those tests. So, but most of the people who have ADHD, sometimes they might perform those tests well, but may struggle with like real life scenarios, like in work or home. So how do we go about that if it comes positive? Like, won't it reassure the patient, or do we underdiagnose? So that's the first part. And the second part of the question is, so like unlike unless we do ADHD for younger people, most of the time, like when these celebrities come up with such diagnoses, you'll see people who are like in their 20s or 30s who come up with some sort of self-diagnosis as ADHD. But most of the time, so since ADHD kind of can mimic depressive disorder or anxiety disorder or even personality disorders, how do we and ADHD can cause these mood depression or anxiety later on in their life due to difficulties they faced in school. How can we use these tests to actually delineate if this is a depression because there's an underlying player of ADHD all along, or whether this is like a completely like a depressive disorder, because we will not be able to differentiate with these kind of quantitative tests.
Okay, Anup, good questions. But I think part of this has been answered in the presentation itself. For example, the Moxo CPT tries to incorporate real-world distractors. The kind of distractions present are real sounds. For example, sounds from a window, other sounds, other objects which the patient may face in real world. And particularly with the advent of such portable equipments, you can send the person to real life situations and have complete tracking data. Even for a complete day in school, you can have complete data. And if you go stretch it along, you can even see what the patient is interacting with. Just like Google glasses or this Meta glasses, you can have device to track what is going on in front, what is happening in the brain, and multiple other data can be gathered. So the possibilities are endless. Then coming to the question of about real world performance, right? All these tests mostly reflect optimum performance, not real world performance. But this optimum performance and some like close to ecological settings can provide an idea how this person will perform in real life situation. Then coming to the question of depression, anxiety, and also personality disorders as comorbid, the question should be, have we divided nature at its joint? So ADHD as a diagnostic entity is something we have defined for our own convenience, so as to say, for diagnostic convenience, treatment, and communication. So is ADHD that pure and simple diagnosis? Or in nature itself, it is like a cloud with blurry edges mixing with other things. It is, for example, some people see cloud and they think it is Jesus or say Shiva or anything, right? So is this the definition we have created, or does it exist in the nature in the same fashion? And even if you see receptor polymorphisms, there is D2, there is D4, there are other neurotransmitter, there are circuit level changes. So in the absence of identifiable deeper biomarkers, that is multiple regions in the brain would contribute to all these symptoms you are mentioning. But we are only picking up inattention, hyperactivity, impulsivity, and calling it ADHD. So that question will always be there because these divisions are not pure. And particularly with personality disorder, we have like moved from a categorical definition to a dimensional description. Then again, the implications for therapy or pharmacotherapy or lack of thereof has so much implications. So that will again go to a diagnosis issue with the diagnosis rather than ADHD as an entity.
Thank you, sir.
Dr. Murugappan? Sir, kindly unmute, sir. Sir, please unmute. Dr. Murugappan, please unmute.
So before that, one more small addition before sir.
Yeah.
So see, for schizophrenia, we have something called virtual reality functional capacity assessment. Rather than asking them to do boring tasks in a clinic and saying that, okay, now you are fit to go out and actually do work in the bank, which most of the patient won't be able to do. So there are virtual reality assisted settings. Even with ADHD, there are a lot of like games, virtual reality settings to assess the performance in almost close to real settings. Again, these are again gamified. These are again virtual reality, which provide novel stimulus, which will alter the performance, right? But in a game, if you want to go and read a book, a kid may be actually interested in doing that. But in a classroom, if you give a book, the child may or may not be interested. So we attempt to simulate that. The real thing will be possible only when such wearables come that you track an entire day, then you feed the data into some like automatic, this AI can assess like huge volumes of data. So you can have transcript, you can have motion tracking data, and you can analyze. That is the only way forward if you have to assess. But then there will be huge questions about invasion of privacy. How much should you track? Then are we becoming automatons? Are we robots? Should be monitored? Then are we under control? It is like implanting a chip to control us forever. So it raises a lot of other ethical and other questions beyond, for a diagnosis, how far will you go to diagnose?
Dr. Murugappan.
Yes. Thank you, Suresh. Srinivas, it was an excellent academic presentation. It was very nice. And I know I have been meeting you for the last 2-3 years. You have been doing it very well. Yeah, now coming to Dr. Karthikeyan's questions. Am I audible?
Yes, yes.
Yes, sir. Yes, sir.
Dr. Karthikeyan, well, QEEG is objective for almost, I used to say it is an evidence-based medicine in psychiatry, QEEG, brain mapping. And for ADHD, you get a lot of biomarkers. QEEG gives a lot of biomarkers for various conditions. For ADHD, you get, see that it is very useful for making personalized medicine in psychiatry. For personalized medicine for ADHD, EEG is very useful. In that sense, you can subtypes ADHD 4 types with EEG alone. And also you are asking about theta beta ratio. And let me come to that. Theta beta ratio specific value is 1.2 to 2. What does it mean? Anything 1.2 to 2 is normal. Above is theta beta ratio is high theta beta ratio. And how is that? But it doesn't happen only in ADHD. You get in a lot of conditions, medical conditions, psychiatric conditions. In the sense, because I have a lot of disturbance here in my career. Theta beta ratio, normally in ADHD, it is in the range of more than 5, 5.5 or 6. And you see, especially with the high theta beta ratio indicates theta waves activity, that is subconscious waves activity, and the problem is processing. The brain is not able to sustain high activity where it requires beta. And wherever there is a reduced oxygen supply, hypooxygenation, the brain goes into theta mode. We call it slow brain. Instead of alpha or beta, it goes into theta mode. So these people with this ADHD, they have high theta activity in the sense the brain is getting lower oxygen. And there are other conditions, especially dementia, MCI. And the clinical presentation will be, they will not be able to process language processing. They will not be good organizers. They cannot understand, evaluate things. And if you're going to talk to the person for a longer time, more than 1 or 2 minutes, they are lost. They go into their own inner dream world. So these ways you can assess theta. The purpose of theta beta ratio, high theta beta ratio, is that the brain is slow. And anything more normally it is about, in ADHD, it is above 5. And then you are asking about cost. It is a brain map. It is not, we are not going to measure only the theta beta. We are going to see that this is an entire brain map, QEEG brain map. It costs nearly about 10,000 rupees. And you get, and it gives, so you are going to measure the 20 sites. It is not 2 sites. You are going to measure the 20 sites. You are going to measure the DMN, default mode network, connectivity. Actually, default mode network is a very huge area that requires a lot of, you don't understand human being, you don't understand psychiatry unless you know the default mode network. It is an extensive network and it is involved in almost all these connectivity disorders. And so with regard to the treatment, it is not a trial and error. When you know the EEG activity, you can specifically choose the type of medicines you need. That is, in ADHD, when there is an excess theta, excess frontal theta, you give stimulants, will be effective. And excess beta, stimulants will be effective. But stimulants will not be effective when the alpha is low. Individual alpha peak frequency, APF, when it is low, it is not going to be effective. That is the cases where you get, you call treatment resistant, you go on changing the drugs. It is not going to be effective. Those cases where alpha is low, where alpha peak frequency is low, you have to try with other modification therapies like neurofeedback, RTMS, TDCS, and behavior therapies. And these cases, they will not respond to stimulants. So for personalizing this treatment, you need QEEG. QEEG can be used as a tool to identify the subtypes. When you know the subtypes, your treatment becomes personalized. So that is personalized medicine in ADHD. Yes, right.
Thank you. Thank you, Dr. Murugappan. Dr. Vasantha, did you want to say something?
Yeah, anyway, I thank Dr. Rajkumar for the insightful talk. The one thing that I wanted to ask was ADHD occurs with a lot of comorbidities. So you said there are some tests specific for ADHD. How specific are they in picking up ADHD in the presence of comorbidities?
Yes, ma'am, that is a very pertinent question to ask. The thing is, these tests can identify inattention, hyperactivity, and impulsivity. These are not like, we are not going to do a genetic test that will point to ADHD diagnosis. So even if there is inattention due to, for example, anxiety or other conditions, when we do detailed data analysis, for example, when we compare with norms, for example, at least with this MOXA CPT, there are different domains. Like, as I said, even day of the week variation has been plotted. Then the inattention resulting from anxiety is slightly different from what happens in conventional ADHD patients. Then the kind of differences in, say, for example, in 1-back versus 2-back versus auditory oddball paradigm, or when you provide distractors. So they have profiled individuals. So it is not a very directly say they give just inattention score or other things. The composite profile can closely go towards ADHD as we have defined it. So there is some discrimination between, like for example, inattention resulting from anxiety or depression or say sleep deprivation or stress. But that is still debated, ma'am. Lot of tests show that there is no difference for some of the continuous performance tests between inattention resulting from say ADHD or some other cause. Because these are neuropsychological tests, they test for specific functions, say attention, response inhibition, or like, motor response time, reaction time, or other variables. They can still be influenced by multiple factors. That again adds to what Dr. Vikas has shared about theta beta ratio. There are a lot of factors that can influence. But these norms are chosen in such a way that, okay, they closely identify with patients with ADHD. That too in specific age group. Beyond the age group, even if theta beta ratio continues to be abnormal, the number of factors that influence or its utility as a diagnostic tool diminishes.
Thank you.
What about ADHD with autism? Because it's quite difficult to treat ADHD when in the presence of autism. How specific are your tests?
So here they say, particularly with the advent of ADHD diagnosis, the newer analysis, for example, at least in fNIRS, they say that in patients with comorbid autism, the incidence of hyperfrontality is less. They say that frontal lobe can actually be upregulated. There is increased top-down regulation of the underlying amygdala's reactivity. So there are differences. So as I said, the previous analysis was simple heat map, but now we are able to do deeper learning, not in sophisticated labs or people with sophisticated computers. We are able to have like basic data sets, do some of the machine learning in our own computers. So because we are able to do more than the basic statistical analysis, we are able to pick up small differences which cannot be seen in report or which cannot be seen in even in, for example, QEEG reports. So simple, small additional analysis on basic data sets will be able to differentiate, for example, comorbid autism or anxiety. I think Murugapan sir would be able to answer better. If two positive findings are there, then there could be like how a combination of multiple signatures helps us to decide where does this diagnostic entity lie. So there are some differentiating factors, ma'am. Particularly with functional imaging, we are able to see other regions also. And as I said, when we look at only one region, for example, frontal lobe, some patients with ADHD, even in our study, we had that the test performance may be normal, still they will show hyperfrontality. So then if we look at the data, if these patients were subjected to fMRI or like, people who have underwent multiple functional imaging, there are other regions of the brain which should compensate for the same function. So usually combination tests are better. For example, you do a complete map using, say, QEEG, then localized data from the frontal region using fNIRS. Then if you are able to combine, you can see that even if there is hyperactivity in this region, some other part of the brain is compensating. And under additional load or under demanding task, it would fail.
Okay, thank you.
Anyone else wants to make a comment? A question?
Good afternoon, all, and thank you so much, sir, for this valuable presentation and very new to us. And don't mistake that I'm asking this question, but I want to do this practically. So, is there any source to get these machines and all, any contact numbers or like that?
Absolutely.
Thank you, sir.
This Muses Athena is available in all countries except India. But in India also there is a reseller, Devi Store, who sells this device. And we are in the process of procuring it. And definitely you can buy it. If you have your friend who is abroad, who is coming, you ask them to buy a device, you can get yourself started. Because this device is like very good. It combines HRV, it combines EEG and fNIRS in one. So it is a good start, though it is a consumer grade device. It provides raw data for access. That there is an additional software called Mind Monitor. You can get the basic raw data. So even if you think it is like small start, it is a good direction forward. When you get sophisticated, like for example, sophisticated data, you will be able to work on it, because this is the basic start towards capturing biosignals, recording, analyzing.
Fabulous.
Thank you, sir. Thank you, sir.
Thank you, Vikas, for putting that link, and somebody can copy that, yeah, thanks. Shanmupriya, Dr. Shanmupriya, you can copy that from Vikas posting.
And there are a lot of YouTube videos. There is a very active group on Reddit. There are a lot of YouTubers who encourage it, and it is in its third generation. So it is not an immature device, so as to say. So it is in its third generation. Then there are a lot of additional software packages over and above that to provide neurofeedback. So not only detecting, you can modify these wave patterns. So rather than treating a diagnosis, treating inattention appears to be slightly easy, though the longevity of response is poor. People who use it, I think Dr. Shubham, who was a speaker in our previous conference, they have 10 devices of Muse, the previous version, Muse 2, and they still have huge demand for individuals, and people with ADHD who use it on a regular basis find improvement. Though the longevity is limited, like once they stop, they tend to mean revert.
Anyone else? Okay. If not, I must say, Dr. Srinivas Rajkumar, your presentation was absolutely great. And I think the way you answered the questions also shows the thoroughness of yours in this particular field. And I really wish you very best in actually continuing to educate us in this particular field. I'm very, very happy psychiatry is in the safe hands of younger people today. They're all highly educated and willing to share their knowledge and educate the seniors. Thank you so much for your presentation, and I appreciate it, given that you have been given only a short time to have this presentation. Even not on a regular day, month and day, we even preponed it for a week. I think you are very, very collaborating with that. Thank you so much for that. So I want to thank all the participants who really highlighted the topic. So thanks so much. Again, I welcome you next month to the welcome. Next month, Manthan will happen on the usual third week. Thank you so much. Have a nice Sunday, a nice weekend.
Thank you so much, sir. Thank you for the opportunity, and thank you all for the intelligent questions. And soon we'll be coming up with a workshop to help you capture biosignals from simple devices, and also introduction regarding neurofeedback soon before this year ends. Thank you so much, and we look.
Thank you, Torrent, for always supporting us with your online support. Thank you.
Thank you, sir.